So what I was saying is that cardiac catheterization, uh, you can have left heart catheterization or right heart catheterization. Uh, we use catheterization synonymous with angiogram. So you might see someone say, do an angiogram, coronary angiogram. It's basically the same thing as a catheterization. Um, and it involves passing a catheter through the femoral vein or artery into the heart. We can also do catheterization through the radial artery. Okay, so we will discuss both approach through the radial artery or the femoral artery. Um, we do these procedures to look at the blood vessel around the heart. So when someone gets a heart attack, it's because they have blockage of the blood vessel around the heart, and they get a heart attack. So we do these procedures to look at the blood vessel around the heart. They may not get a heart attack. They may have what we call angina. Angina is chest pain because of blockage, and it's a more chronic process. So when you do your angiogram, you'll see the narrowing of the blockage. We can also do catheterization to evaluate the heart valve. If the valve is stenotic, that means um, if the valve is stenotic, then um, you can evaluate using cardiac catheterization to evaluate that. Also, if the valve is leaking quite a bit, you can also do catheterization to look at that. But not only that, if the patient's heart valve is really diseased, we need a catheterization and an angiogram before we fix the valve, because we have to look at the blood vessel around the heart to see if it's blocked, especially in individuals over age 40, because you don't want to do your you don't want to fix the valve and then shortly thereafter the patient have either a heart attack or angina to suggest that there is blocked blood vessel around the heart. If you're going to do heart surgery, you'll just fix everything at the same time. All right, so that is catheterization in a nutshell. But we can do catheterization either from the femoral approach or the radial approach. Okay, we can go through the radial artery or the femoral artery. Let's concentrate a little bit on left heart catheterization. And when we talk about left heart catheterization, we enter the arterial system. We go into the left side of the heart. Okay, if we're going through the femoral artery links up with the external iliac, which communicates with the common iliac, and then that goes into the aorta. You have the abdominal aorta. Then once it crosses the diaphragm, you have your thoracic aorta, and then it goes straight up. You have your aortic arch and your ascending aorta. The coronary blood vessels comes off the aortic root. The coronary blood vessels comes off the aortic root. So where you have your aortic root, okay, you'll have what we call coronary sinuses. Coronary sinuses. So the right coronary sinus will gives off the right coronary artery, and the left coronary sinus will give off the left main coronary artery, which divides into a left anterior descending coronary artery and a left circumflex coronary artery. So these are the blood vessels around on the surface of the heart. When these blood vessels on the surface of the heart are blocked, if it's a slow process, if the blockage develops slowly, the patient will get what we call angina pectoris, which is a chest discomfort because of the blockage. And the reason why we say discomfort, because patient will tell you, I'm not having pain. It's either pressure, burning, tightness, squeezing, one of those presentation, rarely the patient going to tell you that, I'm having a pain. So you have to be careful when you try to elicit if they're having chest pains, because the patient will tell you, no, I'm not having chest pain, I'm having burning. Okay. All right. You can also do catheterization through the radial artery. And through the radial artery, we go up the radial artery, we enter the subclavian, and then the subclavian enters the innominate, and then from the innominate we enter the aorta, and then we can cannulate the coronary blood vessels. So at present we have two approach: the radial approach, so you can do the radial artery or the femoral artery. Okay, there's a tendency for more operators to use the radial approach, because you tend to get much more complications with the femoral approach, because they're larger blood vessels and patient can bleed quite profusely. So complications such as hematoma, bleeding, is much more common with the femoral approach as opposed to the radial approach. Okay, and with the femoral approach, the patient, you have to let the patient lie down for a little bit, 2 to 4 hours or more, depending on what's going on. With the radial, you put up a TR band, and within an hour or so, the patient can go home. And you see, because it's in the radial artery, the patient can ambulate almost immediately after the procedure. They can get up and walk around almost immediately. So there's a push now for more operators to do the radial approach. But sometimes you have to revert back to the femoral approach because the radial artery is too small or maybe absent, or, if you have done multiple procedures through the radial artery, you might not have easy access. Okay, so the femoral approach, is okay. So what we do is, the first thing, we cannulate. So we use a needle. Okay, so you numb the area first. We do this in the cath lab, where you have your cameras, and we'll look at the instruments that you need in the cath lab. You need your camera, you need your monitors, you need a crash cart. Those are things, and you drape the patient. If you're going through the femoral artery, then you numb the area. You put a needle in the femoral artery, and because it's an artery, blood is going to spew back on you. And then you put what we call a guide wire. You put a guide wire through your needle. That's a very tiny wire, because you wanna access the arterial system. So you put your guide wire in the femoral artery. Over that guide wire, you put what we call a sheet. So you put a sheet over the guide wire, and that's going to stay in place. That's going to stay in place, the sheet. Okay, that's where you're going to work. You're going to work through your sheet. You always, you're in a artery, you always have to pull blood backwards, because you don't want to push any clot. So you always pull back. Since you're in the arterial system, you'll get a bleed back. So the blood will just flow back. So again, this is just to highlight, this is your aortic root right here. Your coronaries usually come from the sinuses. This is your right coronary artery, which usually come from the right coronary sinus, and then the left main, which comes from your left coronary sinus. So this is the right coronary artery, and you have branches. We talk about a sinoatrial branch, a conus branch. So you have a conus branch, a sinoatrial branch, you have an RV branch, and you have the posterior lateral, and then your posterior descending. So this is the right coronary artery, okay? And then this is the left system. First you have the left main, left main will divide into a left anterior descending coronary artery, which runs in the front of the heart, and then the left circumflex, which loops around the back of the heart. So you have to know the anatomy. Okay, this is basically what we were saying. When you cannulate, if you're in the femoral artery and you cannulate the femoral artery with a needle, okay, what you do, through the needle, you're going to put your guide wire, because you can't leave the needle. Needle is sharp. It will, perforate the arterial system. So you put a guide wire in, just a flimsy little wire, not very stiff. And then over the wire, you're going to put a sheet that stays in place. Sheet is a plastic cannula that stays in place. Okay, so again, when you do your radial approach, remember your radial artery eventually comes up, and you have your right subclavian, which goes into the nominate artery, which enters the aorta, and then you can come down the aorta and cannulate the blood vessels around the heart. The same thing, you put your femoral arteries, your radial arteries right there. You cannulate it with a much smaller needle. So you're going to cannulate the radial artery. Then you put a guide wire. You have special guide wires that you put in. Then you put your sheet over the wire, and the sheet stays in place, because you're going to work through the sheet. The sheet stays in place. It's a plastic cannula. Okay. And anytime you're going to work in any vascular system in the heart, you have to use guide wires, because these guide wires allow easy access to the vascular system and prevent injury. So it's very important to you have to use guide wires. You can't do the procedure unless you have guide wires. So again, when we talk about cardiac catheterization, we talk about angiogram, and this is the left side now. So we're talking about left heart catheterization. So we talk about angiogram, that is looking at the blood vessels around the heart. Okay, that's called angiogram. So when you look at blood vessels using a dye technique or an imaging technique, we call that an angiogram. We can, the reason for that is because the patient may have a heart attack or angina, which suggests blockage, and you want to do a balloon angioplasty, that you use a balloon to open the blockage, so to speak, or you might want to put a stent in place. If the patient has a blockage, you want to put this little metal tube in to keep the vessel from collapsing. We're now doing heart valve replacement via catheter approach. So instead of opening the patient's chest, we can replace the aortic valve through going through the groin, catheter approach, and we can repair the mitral valve also via catheter approach as well. So these are some of the conditions that catheterization allows us to do. So this just show you when you can use either the left or the right femoral artery, but the approach is the same. You go up into the aorta, you go up your descending thoracic aorta, the aortic arch, the ascending aorta, and you want to get to the aortic root, because again, remember, the right coronary artery usually comes from the right coronary cusp. The left coronary artery comes from the right coronary artery from the right coronary cusp, and the left coronary artery from the left coronary cusp. Okay, so it's important. So when we're doing the left heart cath, we come up the aortic arch, the ascending aorta. Then so we cannulate. We put the catheter in the right coronary artery and we inject dye. So the blood vessel is not gonna light up unless you inject dye. Once you inject dye, then the blood vessel will light up. Um, and you do the same thing for the left coronary artery. Okay, you cannulate the left anterior. You cannulate the left main coronary artery, and you inject your dye, and it will light up the left anterior descending coronary artery and the left circumflex. Okay. We also want to look at the pumping action of the heart. When we talk about left ventricle, the ejection fraction. To get the ejection fraction, we put what we call a pigtail catheter. So it's twisted or curled like a pigtail. We put this catheter in the left ventricle, and we just inject dye, and then because the heart is contracting and relaxing, we can see the pumping action of the left ventricle, and we can determine the ejection fraction by that method. And the reason why the catheter is curled up is because we don't want to traumatize the heart muscle or any of the structures in the heart. So that is why, if we curl it like that, then we have a blunt uh, surface which enters the heart, minimize trauma. Okay, so this will, it's a pigtail catheter in the left ventricle. We inject dye and then look at the heart pumping the dye out, and we'll get an idea of how well the heart is pumping. Okay, so what are some of the reasons for doing cardiac catheterization? Again, we talk about chest pain. We call that angina, but it's more, patient will describe what's going on in the chest. It's in majority of the cases not really pain as you know it to be pain, but it's pressure, tightness, burning, you know, discomfort. Those are the discomfort that the patient will tell you about. And most of the catheterization that we do is for angina. You know, we suspect blockage of the blood vessel around the heart. That's the reason why we do the catheterization. All right. Or the patient presents with heart failure. So a patient presents with heart failure, and we think that the heart failure is because of blockage of the blood vessel around the heart. We can also do the catheterization. And of course, if the patient have any valvular heart disease, we might want to evaluate the valve itself via catheterization procedure, or if the patient is going for surgery, the patient may be going for valve replacement or valve repair. You want to look at the blood vessels around the heart, because if you're going to open the patient's chest, you want to do all that you can do. You don't want to open the patient's chest, replace or repair the valve, and then 2 months later the patient have a heart attack, and you have to open the patient's chest again and do bypass surgery or something like that, or a stent procedure. So it's customary, if you're going to do surgery for a heart valve and the patient is over age 40, for you to do a catheterization to look at the blood vessels around the heart. So again, chest pain, shortness of breath. Once you suspect that there's a problem with the heart, the blood vessel around the heart, catheterization is indicated. And so in the cath lab, there are certain instruments that we have in the cath lab. This is a camera. So okay, so you have to have your camera in the cath lab. I mean, this allows you to see inside in the vascular system. Okay, you're going to be threading your guide wire and your catheters up to the heart, and you have to follow the progress. So this camera system, okay, allow you to follow your guide wires, your catheters, and then when you cannulate the blood vessels, you can see what you're doing, and then you inject your dye and take pictures. So the camera allow you to see. Okay, we use fluoroscopy to see And then when we're taking pictures, we use cine angiographers. We use cine. Okay, so we use cine uh, to take the pictures, and then just to look and see what you're doing, fluoroscopy. Okay, so you will have, so of course this is your camera system. Then you're going to have monitors. You you'll have monitors so you can see your images. Okay, so you want to see what you're doing. I mean, the camera is on the patient, but you're going to see where you are and what you're doing on these monitors. And then there's a monitor for hemodynamics. So you have to see your ECG, and you have to look at pressures, because sometimes you won't know if you're running into problem unless you look at your pressures. If your pressures are very low, then you have to, do you have a blockage in the catheter? Is the patient bleeding out? Is the patient, what complication? What is happening? So the hemodynamic monitor is crucial. So you have a hemodynamic monitor with your ECG on that monitor as well, and then your imaging monitors. Okay, you're going to have additional individuals um, in the room with you. You should have a technician that is scrubbed and working with you. And you also need a floating nurse. So a nurse to get stuff. If you need anything, you need a catheter, you need medication, then you need the nurse to go and get that for you. And also outside of the room, you have technicians that are monitoring, minimum of one technician that's monitoring the monitors outside. Once you're inside the cath lab, once you're inside the operating area, you need to have lead shields, because we use the fluoroscopy, and the cine gives ionizing radiation, which can cause problems with cancer and infertility and stuff like that. So we usually use a lead shield. So at the front, and in some situation you have a complete lead shield that goes around you. So it's just an apron. So we have an apron which is um, which have a lead inside the apron, and sometimes you also get a thyroid shield. So you get a thyroid shield, and because you're doing a sterile procedure, you need to gown up, you need to have your mask, your cap, stuff like that. And the patient is draped. It's a special table you need. And then this is what we call an injector. Injector. When we enter when we're in the left ventricle, when we're in the left ventricle, we use a pigtail catheter. So when we enter the left ventricle, or pigtail catheter, we're going to inject dye into the left ventricle and see how well the left ventricle pumps the dye out. You need an injector, because you need an injector to pump the blood into the left ventricle. Okay, because remember, the left ventricle, there's a lot of pressure there, so you need something that can supply sufficient force to inject dye into the left ventricle. So this is an injector. Okay, of course you need your table with your supplies and stuff like that. Um, so this is what the actual room looks like. So your table, your patient, your camera is right there. Okay, you have your monitor which shows the images. So these are imaging monitors, and then this hemodynamic monitor. You have your ECG, and you have your cardiac pressures. It might be the left ventricular pressure. It might be the aortic pressure, the coronary pressure, whatever it is. Um, you have your stand with your IV fluids and all that good stuff. Very important. You need to have a crash cart. Crash cart. So this contains emergency medications. So if the patient develop any, if the patient develop arrhythmia, whatever, you have medication to resuscitate the patient. Okay, the crash cart with medicines, and then one or two technicians outside where they are also looking at the monitor, the hemodynamic monitor, and they can see the images as well. But these technicians are logging in, what you're doing, minute by minute. They're putting in, you gave this medication, you enter the femoral artery, you put your guide wire in, they're sort of doing the notes, so to speak, and they're putting in the information. And extra set of eyes, because if your pressure is falling and you didn't notice, they can also tell you that your pressure is falling. Also, the technicians and the nurse inside the actual room will alert you to these problems. So once you're inside the room, you need your lead shields. Okay. So this is inside a room, and then outside the room, so there's a glass there so that these technicians can observe what you're doing. Um, once if you're outside of the operating space, then you don't really need a lead shield. So these individuals don't need a lead shield. Once you're inside, then you need a lead shield. All right, so these are some of the catheters that we use, and you need to familiarize yourself with them. Okay, the common ones that we use is Judgkins. We use Judgkin left, Judgkin right, and the curvature is the important thing. So your Judgkin right looks like this. When we're going to cannulate the right coronary artery, we use the Judgkins right. Okay, and the curve is such that it allows relatively easy cannulation of the right coronary artery. This is the Judgkins left. You can see the curvature. We use this to cannulate the left main coronary artery, the left system, Judgkins left. And we have different size curvature, because a smaller individual is going to need a different size catheter as opposed to a larger individual. So we have different size curvature, small individuals as opposed to a large individual. So this is a multi-purpose catheter. It has no preform curvature. Okay, so you can see your Judgkins right has a preform curvature. The left has a preform curvature. Your multi-purpose don't have any curvature. But the beauty about the multi-purpose, you can manipulate it to cannulate the right and the left coronary artery. So instead of using two different catheters to cannulate the right coronary artery and the left coronary artery, with the multi-purpose, you can use this to do your complete procedure. You can use it to do the complete procedure. You can use it to do the right, the left, and even the LV gram. The problem with this catheter, however, is because there's no curvature, you can sometimes you can damage the cardiac structure if you're very aggressive. Okay, because you have to create the curvature. Once you start doing the procedure and you get to the aortic root, you have to create the necessary curvature to cannulate the right coronary artery, the left coronary artery. So you have to manipulate this catheter quite a bit, and you can cause trauma. So you have to be careful. This is what we call the internal mammary catheter. Use it a lot of time to look at bypass grafts. We'll get to that at some other time. Bypass graft. Another catheter we use quite a bit is the amplast. Sometimes you can't get the right coronary artery. You can't get to the right coronary artery easily because the takeoff might be a little bit abnormal. So the Judgkin right is just not working, and we revert to the amplast catheter. But you'll get to learn these catheters and know when to use them. So this is when we do an angiogram. These are the blood vessels on the left side of the heart. This is what we call the left main coronary artery. left main coronary artery. It gives the left circumflex, which comes down right here, and then the left anterior ascending coronary artery, LAD, which comes right down there. And of course, there are branches of these blood vessels. But once you look here, you see that there, it's like somebody bite out a piece of this blood vessel. This is where you have the obstruction. This is where you have the narrowing. So this is a significant narrowing, and we would intervene if the patient is having symptoms. All right, so the purpose of doing catheterization, looking at blood vessels around the heart, is to see if there's any obstruction. So this is a good example of a significant obstruction. This is in the left circumflex. So this patient, if their presentation is angina or a heart attack, then this is the individual we would put a stent in. Okay, so all right. So we've been talking about left heart and right heart catheterization, and if you recall what I said, that to get to the left side of the heart, we usually enter the femoral artery or the radial artery. However, we can get to the left side of the heart by what we're doing we call a transeptal puncture. Transeptal puncture. So if this is the right side of the heart, the left side of the heart, and say we come up through the inferior vena cava. If we do the femoral vein approach and we come to the inferior vena cava, even if we come to the superior vena cava and enter the right side of the heart, we enter the right atrium, we can puncture the atrial septum and enter the left side of the heart. So we can work in the left side of the heart. And commonly, when we were repairing the mitral valve, the procedure we call mitral clip, we use the transeptal approach, and we enter the left atrium, and then we go across the mitral valve and work on the mitral valve. Transeptal approach. Also, if you're going to do electrophysiology study, it's very common to do atrial transeptal approach, where you cross you puncture the atrial septum. You go into the left atrium, and you can work from there. As we had mentioned before, hemodynamics is a very important part of what we do. So you have to know hemodynamics. And so remember, we have one old monitor that's reserved for ECGs and the pressure tracings. So when you're in the aorta, you're going to get a tracing looking like the top curve. Okay, so this is the aortic pressure tracing. Okay, so you're going to have a diastolic pressure, okay, and a systolic pressure. So if you look down here, you have your ECG right there. So in diastole, and you remember, what is diastole? We talk about, if you look at your ECG, diastole is from the end of your T wave to your QRS. So this pressure in the aorta is diastolic, and then systole is from your QRS to the T wave. So all of this is systole. So the aortic pressure, because the left ventricle contracts in systole, force blood into the aorta, so the pressure is going to be higher. So you have a systolic pressure in the aorta and a diastolic pressure which is lower. So this is the aortic pressure tracing. You have a diastolic pressure, okay, and you have a systolic pressure, okay. So of course, the systolic pressure is lower than the diastolic pressure. When your catheter now enters the left ventricle, you're going to see that the diastolic pressure in the left ventricle is going to be lower. So the diastolic pressure in the aorta higher, diastolic pressure in the LV is lower. But in systole, the pressure in the LV is supposed to be the same as the pressure in the aorta. They tend to have the same systolic pressure. The LV, however, the diastolic pressure is lower. Okay? So in systole, the LV pressure goes up, and in diastole, it falls. That's because it's already pumped the blood out and is now ready to fill again. Okay? Your RV pressure, so the pressure in the right ventricle, if you're doing, say, a right heart catheterization, the pressure in the RV is going to be similar, but at lower. The pressure in the RV is going to be much lower. The systolic pressure is going to be much lower. Okay? The pressures on the right side are lower than the pressures in the left side. So your RV systolic pressure is going to be much lower. The contour is going to be similar. The diastolic pressure should be the same though. The diastolic pressure in the RV and the LV should be the same. And you also can look at the pressure in the left atrium. The left atrium pressure is going to be relatively low. You know, when you have ventricular systole, you have blood flowing into the left atrium because the mitral valve is closed. Okay, so all throughout systole, you're going to have a certain amount of pressure, and then when the mitral valve opens, you will have the left atrium contracting. So the pressure goes up a little bit when you get to the end of left ventricular systole, because the atrium contracts, so the pressure bumps up a little bit. But in diastole, it falls. Okay, so this is left atrial pressure tracing. The right atrial pressure tracing is somewhat similar. Okay, so these are the stuff that we look at in the cath lab. Of course, you're going to have your ECG, and you have to monitor that, because if the patient goes into complete heart block, patient develops ventricular tachycardia, ventricular fibrillation, you should be able to identify that. But the pressure tracings are crucial. So you need to go over the pressure tracings. You need to be able to draw them and know what's normal. Okay, so there are a few complications that we'll get in the cath lab. And one of them is what we call a vagal reaction. You know, you're working in the groin and you're doing all sort of stuff. You enter the heart. So it's not uncommon for the patient to have a vagal reaction, and that will manifest itself hypotension. You see the blood pressure falling, you see the heart rate falling. The patient will be pale, diaphoretic. Sometimes they vomit. You know, they start vomiting. So you have to know what's going on. You know. So if it's just a vagal reaction, you need to make sure the airway is fine. I wouldn't go as much as elevating the legs just yet, but you can open fluids and give atropine. The treatment for that is atropine. You know, if the patient is definitely not responding, then you can elevate the legs. But vagal reaction is fairly common. So what are some of the complications that we can encounter when we do this procedure? Again, remember what we said. When you use the femoral approach, because it's a large blood vessel, it's a arterial system, it's pumping blood, the patient can, you know, have tremendous hemorrhage, especially if they're anticoagulated or there's some other pathology. They can bleed out fairly quickly. So hemorrhage, you have to take care. With the radial approach, because they're much smaller blood vessels and you have much more control over the blood vessel, you don't usually see significant hemorrhage. Injury to nerves, especially the femoral approach, because the femoral nerve lies pretty in close proximity to the artery, so you can traumatize the femoral nerves. Of course, you know, arrhythmias, the patient can develop ventricular tachycardia, ventricular fibrillation, heart block, complete heart block. So you have to make sure that you're set up to take care of these, because I have encountered about two or three occasions. Once I cannulate the right coronary artery, the patient went into ventricular fibrillation. Now, if you don't take care of this immediately, you can lose the patient. The patient can die. So you have to recognize what's going on, and then you quickly shock the patient to get them out of that. Once you do that, no problem. The patient won't even know what went on. But it's very common, fairly common, for you to get ventricular fibrillation when you cannulate the right coronary artery. Okay. Um, allergic allergic reaction to the contrast. You're using iodine contrast material. Some patients will develop allergic reaction, and it's profound. Once you diagnose what's going on, you'll be okay, because you can treat the patient. You can get a stroke. That's why you have to take care of what you're doing, because if you inject blood clot in the arterial system, it can travel to the brain. Patient can get a stroke. The contrast material can damage the kidney. So these are some of the complications. Contraindications: you don't want to do the procedure if the patient is taking blood thinners, especially the femoral approach. The radial approach, you're okay. But the femoral approach, if the patient is taking any blood thinner, they can bleed out, and you don't want to do it. If the patient is in acute heart failure, you want to wait until they're compensated. Uncontrolled hypertension, if the patient is pregnant, inability to cooperate, active infection, renal failure, contrast. So these are actually relative contraindication, because if you need to address the cardiac condition immediately, sometimes you ignore all of this, and because if the cardiac condition need immediate attention for the patient to survive, you have to do it. And so the discussion was mainly on left heart catheterization, but we can also do right heart catheterization, where we cannulate. We go through the venous system and we enter the right atrium. Okay, we do right heart catheterization for patients with heart failure. We're not sure what's going on. We can also do it for acute myocardial infarction, acute heart attack. If the patient have any lung disease and we want to look at, say, the pulmonary pressures and stuff like that. Also for some valvular heart disease, patients who have cardiac transplant and you want to look to see if they have any rejection of the transplanted heart, we do what we call endomyocardial biopsy. Okay. So that's a very important indication. So one of the catheters that we use to cannulate the right side of the heart is what we call the Swan-Ganz catheterization. And the catheter looks somewhat like that. Okay, you have the main portion of the catheter. Okay, you will have what we call a proximal. There's a little hole right here, proximal injection port, if you want to inject anything. So it's a little hole right there. Then this is what we call a thermistor. It's basically a thermostat that because we use this catheter to do what we call cardiac output. So you need a thermostat, thermostat to do that. So a thermostat right there. There's a balloon to anchor the catheter in the capillaries, pulmonary capillaries, and then there's a distal lumen where you can you can remove blood, or you can inject material. The distal lumen it's open. So this is the basic structure for Swan-Ganz catheter, and then these are the different ports which allow you to access. If you want to inject something in the proximal port, then you do it through the proximal injection hub. So different hubs. This is for the thermostat. This is for the distal lumen, and this is for the balloon. Okay, this is what a Swan-Ganz catheter. We use this in the right side of the heart. And this is what it actually looks like. Okay, so these are different hubs. The distal lumen is right there. The balloon is usually about right there, and then the thermostat, um, and you have a proximal port somewhere down here. Okay, this is a thermostat. We use it when we want to do cardiac output. Then we'll connect the thermostat to a special monitor, and we use uh, a cool solution. Okay. Um, so we're going to stop here. Um, it's